director of the Osher Clinic here at the Brigham. The rest of the team is at the Osher Collaborative meetings. There are now 7 Osher centers, and they're all, sorry for them, are in Stockholm talking to each other. That's where one of the first Osher centers, it's a research center in the Karolinska Institute. So I'm here to introduce our speaker today, and it's interesting to me because as a clinician, one of the things that's important to us in integrative medicine is teaching self-care. And there's a lot of obstacles to self-care, some of which I hadn't thought of until I heard about this talk. So I think it's going to be fascinating. Abigail Batchelder is an assistant professor of psychology at Harvard, a psychologist in MGH, and does research, was doing till a moment ago, at the Fenway Institute. I'm very interested in seeing what we can do better to help people take care of themselves, and even people who have a stigma attached to their illness or some other problem that causes them to be ashamed, which, by the way, seems to be part of many illnesses that people don't talk about, especially, for example, depression. So I look forward to this talk. Abby.
Thank you. Thank you for having me. It's a real pleasure. I was involved at the Osher Center, with the Osher Center at UCSF, University of California, San Francisco, and I'm excited to be doing something with the Osher Center here. So I'm going to tell you a little bit about my work, including how we can use self-compassion to reduce intersecting stigmas in relation to self-care among people living with HIV and substance use disorders. So I'm going to start with a brief case example to give you a sense of the types of individuals that I tend to work with. I'm going to go over a little bit of background, some of the theories that I use, as well as some epidemiological data around HIV and substance use, and then some background on stigma and shame and how people focusing on these issues are thinking about it in the research to date. I'm then going to tell you a little bit about a pilot intervention that I developed and did really a proof of concept study at UCSF, University of California, San Francisco. Then I'm going to tell you a little bit about my work now that's happening over at Mass General as well as the Fenway Institute, and wrap up with some future directions. So just to give you kind of a flavor of the types of individuals that I tend to work with, I'm going to tell you about a young man that I worked with in San Francisco. And this is someone who came in interested in the intervention that I was piloting. And he was a fairly typical individual that I might work with. He was young, 26 years old, Hispanic, gay-identified male, diagnosed with HIV just a few years prior to coming in, and he met criteria for substance use disorders. He actually met criteria for stimulant use disorder, particularly crystal meth, and alcohol, mild alcohol use disorder, but no other psychiatric diagnoses, despite depicting or conveying substantial distress related to some of his behaviors and some parts of his identity. He was in a relationship, a primary relationship with an HIV uninfected male partner, and they had an agreement that they both engaged in sex outside of the relationship. For this young man, it was usually within the context of what we might refer to as a party and play scene. So using substances and having sex as sort of, that's the event together. And this young man felt really bad about some of his behaviors. And while he was virally undetectable, during the time I was seeing him, he had a history of being detectable. And he described substantial shame related to his substance use and engagement in sex within the context of substance use. So you can see how kind of this picture might unfold, right? So this is a young man, substance use disorders, HIV, distress, but not quite meeting criteria for something like major depressive disorder or an anxiety disorder. And I'm just going to leave that there, and I'm going to circle back to it later on in the presentation. So just to give you a quick kind of snapshot of me, I'm a clinical health psychologist with a background in public health, long-standing interest in social justice and public health in general, and that's sort of what motivates me. I started working with people living with HIV in 2007, and most of my work to date has focused on or has been in urban substance use and HIV-related clinics, many of which were fairly low-resourced. And that was partially because many of them were public hospitals like San Francisco General, but also because of the high need of the patient population. Most of the individuals I work with are living with HIV, as well as a long list of other challenges. And a lot of my research has focused on people living with HIV and hepatitis C in conjunction with substance use disorders. And through this work in New York, where I trained and lived for most of my adult life, and then in San Francisco and now in Boston, I've repeatedly heard a very similar narrative from a lot of the patients or individuals that I work with. I've heard, look, Abby, when I feel bad about myself, when I feel less than, when I feel not good enough, I don't take my meds, I don't go to my appointments, and I use more. When I feel better about myself, when I feel deserving or worthy, I take my meds, I go to my appointments, and I use less. And for me, in graduate school, I was focused on depression mostly as a barrier to engagement and adherence, which we know to be the case. And I actually switched over after hearing this narrative enough times. I thought, we should understand this better, right? This is often sub-threshold for diagnostic criteria, but a real barrier to engagement in self-care. So I pursued this line of work. So from a theoretical perspective, I would say, a public health psychologist in some ways, in that I would say I have an ecological perspective. So while my training is really focused on the individual level and intervening at that level, I definitely think about people within an ecological framework. So thinking about societal level factors, community, relational, in addition to the individual. And especially for people that I work with, I think that thinking about all of these concurrently is really important to identifying those individual level needs. I also think that it's very important to think not only about problems, but also empowerment and resilience. So in my work, I really do try to work with people to feel empowered themselves, right? To have sustainable impact over time in terms of addressing many of these long-standing challenges. And then I also do think a lot about syndemic theory. And syndemic theory is this idea that afflictions or problems synergistically perpetuate one another among vulnerable populations. It was originally described by Merrill Singer, who's a medical anthropologist, and he described the SAVA syndemic, or substance abuse, violence, and AIDS. And he talked about how these things interact to exacerbate the problems, each of those problems. And I find it to be very applicable when thinking about the patient populations that I work with. So really quickly, as I know most people in the audience are not HIV focused, a little bit about the HIV epidemic in the US. There are over 1 million people living with HIV in the US today, and about 40,000 acquiring HIV annually. Gay, bisexual, and other men who have sex with men make up a disproportionate a number of those individuals. And within that disparity, there are also racial and ethnic disparities, in that African American or Black men who have sex with men make up a disproportionate amount of those individuals, as do Hispanic and Latino MSM. In fact, or men who have sex with men. In fact, in a recent article a couple years ago, there was a pretty horrifying statistic that a young Black or African American man who has sex with men had, under 18, had a 1 in 2 chance of acquiring HIV in his lifetime. Unacceptable. So there are major health disparities that need to be addressed in the HIV epidemic in the US today. So in terms of HIV and substance use, at the beginning of the epidemic, injection drug use was a major factor in terms of incidence rates across the country, particularly in poor urban settings. Today, that as a risk factor has gone way down. However, alcohol and other substance use remains associated with HIV acquisition, transmission, and self-care behaviors. And part of that we can link back or think back to syndemic theory, in that substance use has been identified as being associated with other psychological or psychosocial challenges to HIV acquisition, transmission, and self-care behaviors. So if someone is using and they have depression and they have a history of trauma, they're more likely to acquire HIV, transmit HIV, and engage in poor self-care behaviors like poor adherence. In addition to that relationship that has been identified in the literature by Ron Stahl and others, we know that there are stigmas or social hits that come along with something like substance use disorder. And we know that people in the LGBT community experience that substance use related stigma in addition to other stigmas. So another theory that I think is worth mentioning is the minority stress theory, written about by Alon Mayer and others. And this really talks about this idea of social structure or social status contributing to health outcomes. So we know that there are disparities in public health and in health outcomes in general, some of which we just talked about. And there are hypotheses that is attributable to stress experienced due to prejudice or stigma. And some think that there might be a mediating relationship with coping resources or coping strategies. So that someone with a stigmatized identity, for example, might get, experience prejudice and stress and therefore have health outcomes. And they also may have coping strategies that either can intervene in a positive way or exacerbate that problem. So I think about minority stress theory when I think about my experiences and the narrative that I've heard over and over again in that, look, Abby, when I feel stigma, when I feel shame, when I feel lower levels of self-worth, I'm not engaging in self-care behaviors as much. And that has really led me to think about this kind of pathway. So if we have someone living with intersecting stigmatized identities, like being a person living with HIV, being a person who uses substances, and being gay, say, then what's the pathway to reduce self-care behaviors? And I'm thinking a lot about in this work, internalized stigma, and then the affective correlates of that, or self-conscious emotion, which I'm going to tell you a little bit more about. So just to pull back the lens a little bit and give you a sense of the literature to date, we do know that psychological variables have been associated with lower levels of HIV self-care, depression being maybe the most famous one. We also know that internalized stigma and to a lesser extent self-conscious emotions have been identified as barriers to HIV self-care. And internalized stigma has been defined in various ways, but one way of thinking about it is the adoption of other stigmatized opinions. So society has a stigma against a certain identity, then I might take that in and feel that myself, and that might be internalized stigma. Self-conscious emotions are emotions that we can think of as being sort of the affective correlates of this kind of experience, but also really just any kind of affective experience that involves self-reflection or self-evaluation. So these are things like shame or guilt or embarrassment, and a positive self-conscious emotion might be pride. So qualitatively, we've seen that self-conscious emotions have been reported as barriers to HIV self-care and barriers to reductions in substance use. But surprisingly little quantitative research has been done looking at this pathway. So really quickly, I'm going to do a little bit of a deeper dive into negative self-conscious emotions. So while negative self-conscious emotions involve this self-reflection and self-evaluation, that really means that they're social emotions. They're emotions that we experience in relation to other people and how we see other people. So, and how we see ourselves in relation to other people. So, and affective scientists have differentiated these, but really, how do I see myself? Am I less than? Am I better than? Am I just as good as? That kind of thing. So affective scientists have differentiated negative self-conscious emotions, guilt being feeling responsible or remorse for a behavior, whether real or imagined. And guilt is an emotion or affect that usually elicits a reparative response. So I want to apologize, I want to make it better, I want to fix it, Embarrassment is an emotion that's described as feeling exposed or awkward, maybe feeling a little regret, and it's usually fleeting. It's usually briefly experienced. Whereas shame is really feeling humiliated or disgraced or painfully embarrassed related to something about oneself or one's identity. So that's a different kind of emotion, and it tends to be more long-standing. Shame also, interestingly, is known to elicit two types of behavioral responses. Avoidance, which I think we can all relate to. I feel really bad. I just want to go home, pull the covers over my head, and go to sleep. I just don't want to deal with it anymore. I want to avoid. Shame also has been known or identified as eliciting a desire to change oneself or one's behavior, making it a potentially powerful emotion. And this is consistent with some of the literature to date. In fact, shame has been associated with higher likelihood of relapse among people with alcohol use disorders. And it's also been associated with longer duration in rehab, so choosing to stay in for longer. So having said all this, shame may be a unique point of leverage for behavioral change if it can be, dealt with in a meaningful way. So one of the reasons that there's minimal quantitative data out there looking at shame in relation to self-care behaviors is because it's thought to be negative self-conscious emotions in general are thought to be underreported, making them difficult to assess and address. And there are several reasons for that. One is that asking someone to report on how much shame they feel or how frequently they feel shame requires that they're aware of their emotions, one, requires that they're willing to disclose them, two, and requires that they're able to accurately distinguish between multiple emotions. So to distinguish between guilt and shame and embarrassment, for example, which is something that not everyone is really able to do or willing to do. However, there is some emerging work indicating that there's some nonverbal behavioral responses that may be indicative of negative self-conscious emotions. Jessica Tracy at the University of British Columbia has done some postural coding such as these, and there are some other potentially creative ways to measure these emotions. So back to my work. So, you know, all of my work to date has really led me to start to think about some of these problems in this kind of framework. And, you know, as I said, most of the individuals I work with are living with multiple stigmatized identities, or we can conceptualize it in that way. You know, living with HIV, being a person who uses substances, being LGBT, being poor. Many of the individuals I work with are homeless or marginally housed. And for some people, not everyone, but the people that tend to come into a clinical research setting or a clinical setting that I interface with are often individuals who have internalized some of that stigma that society has put out there. And for some individuals, that internalized stigma has led to a negative sense of self or negative self-conscious emotions. And for the individuals I've been talking to over the past 10 plus years, that seems to lead to an avoidance response. That, you know what, Abby, I feel really bad about my HIV status. I feel bad about my heroin or meth use. I'm not going to take my HIV medication because it reminds me of my diagnosis or reminds me of my stigmatized identity. Or I don't want to go to the doctor because it reminds me that I have this illness or that I'm a person who uses substances. And that pathway is something that I've seen over and over and over again. And it makes sense with the affective science literature. This also led me to think about, okay, well, what can we do to intervene on this pathway? What are the additional trainings or information that I can get to try to intervene? And that's really where self-compassion comes in, and I'm going to tell you a little bit more about that work. But it made me think about emotional awareness, metacognitive awareness, mindful self-compassion, those kinds of things, in order to be able to have that desire to change one's behavior or oneself. So at UCSF, actually, I was at the Osher Center in a T32 before I was asked to come to Mass General, and I got this grant to develop and refine an intentionally low-cost intervention to address stigma and shame as barriers to HIV self-care among people living with substance use disorders, and then to test it. In a very small proof-of-concept study, would people living with HIV and active substance use disorders do this? And I wanted it to be low-cost because I wanted it to be applicable to the clinics or usable by the clinics that I was working in that were under-resourced, understaffed, and didn't have a lot of extra bandwidth to treat a non-ICD-9 code problem or barrier to self-care. So during this time, I sought out mindful self-compassion training, and given the audience, I'm just going to tell you a little bit more about that. So Kristen Neff and Chris Germer have developed this mindful self-compassion protocol, essentially, and it parallels MBSR, mindfulness-based stress reduction, with a focus on addressing self-criticism and self-loathing. So you can see how it might be applicable here. And the goals of mindful self-compassion are really to pause and notice your experience. These are all going to sound really familiar probably to this audience. Become mindfully aware of your experience without judgment, harshness, and resistance, and offer yourself kindness and compassion for having whatever experience you're having. And there are three components of this intervention: self-kindness, common humanity, and mindfulness. And I'm just going to spend a few minutes, given the audience here, to talk about these and talk about how they define them. So self-kindness from Kristen Neff and Chris Germer's intervention is really thought of as being understanding towards ourselves when we suffer, fail, or feel inadequate, rather than ignoring our pain or engaging in self-criticism. The element of common humanity really recognizes that suffering, personal inadequacy, and imperfection is part of our shared experience. So not only does it normalize experiencing pain and suffering, but it also facilitates feeling like you're not alone in that. And then the mindfulness, which involves non-judgmental receptive mind states in which one observes thoughts and emotions as they are without trying to suppress or deny them. So with that kind of in my back pocket, or having gone through that training, I then embarked on developing a relatively brief intervention for individuals living with HIV and active substance use disorders who were struggling with internalized stigma and shame. And I did this very iteratively. So I had content that had been developed and identified as evidence-based, and I identified 10 providers ranging from infectious disease doctors, addiction medicine, physicians, psychologists who work with HIV and substance use, social workers, and case managers. And I took the content and I first asked, okay, you guys, do you think this is a problem? And then I said, okay, what do you think of this content? And then I went back and I revised it, and then I brought it to the next interview, and then I asked them the same questions, and I iteratively developed it. I asked them about length, I asked them about number of sessions, I asked them about a text component that I ended up developing. And essentially, I got a strong response, yes, this is needed, this is an unmet need. In fact, one physician said, there's a lot of internalized stuff going on. Some days when I'm in clinic, all I feel I'm doing is de-shaming people. Yeah, they come in not able to do anything because they're feeling so bad about themselves. Another physician said, I had a patient who was just not taking her medication, and I didn't understand why. It was just a few pills every day. I finally asked her, and she said it was like getting diagnosed every time she took them. So in addition to this initial buy-in, physicians and other providers gave me feedback on content. They gave me feedback on how many sessions individuals could go to. They said, you need to pay for transportation. We had several people who were street homeless, which we did. We developed a text platform that would enable the intervention to extend beyond the face time or the person time that was required, that I'm going to tell you a little bit more about. So then I ended up having a 5-session intervention with a text platform that was intended to extend the effect of the intervention. And then I brought in 2 individuals who would meet criteria for the study and ran the materials by them. And that was another iterative process, and it involved several changes, including bringing down the literacy level of most of the exercises, including the mindfulness exercises that we leveraged. It also involved changing several things, like some of the worksheets. For example, some of you may be aware of some of the emotion exercises that are out there. They tend to have cartoons on them. They sometimes can look like they're maybe child-oriented. So one of the participants in this iterative process said, Abby, this is a little bit condescending. So, you know, I was at UCSF. I heard through my network about Dasher Keltner at Berkeley, who was doing something with Facebook with facial action coded emojis. I emailed him, we got them, we put together a new glossary, and the participant said, yeah, that's more adult oriented. So we used that. And so there are multiple changes like that to try to meet the patient population where they were. So the actual intervention essentially looked like this. There was a baseline research visit where we did a full psych assessment, 5 individual sessions that were an hour each, and then a text, I'm calling it a bidirectional text platform that went for 2 months after the 5 weeks of individual sessions. I'm going to tell you what that involved, but it was really intended to model cognitive restructuring, if you will. So the intervention itself, those face-to-face sessions, involved or leveraged multiple evidence-based content, including cognitive behavioral therapy for adherence and depression, which is a behavioral medicine intervention that talks about strategies for improving adherence, and appointment attendance and other things. Life Steps, which is akin to that, which is Steve Safran's 1-session intervention, but it also involves very practical ideas like setting an alarm on your phone or putting sticky notes up, that kind of thing, to help you engage in self-care behaviors. This intervention also really leveraged the revised stress and coping theory, thinking a lot about pathways like avoidance as ways of coping and really trying to reframe that or reappraise. It also involved mindful self-compassion, as I said, and mindfulness-based relapse prevention. And really, you can break it down. Each of the 5 sessions had 3 pieces of information or 3 prongs in it. A metacognitive awareness piece, a cognitive reframing piece, and a self-care goal setting piece. And the metacognitive awareness piece really involved non-judgmental awareness of your emotions and thoughts. We were not trying to help anyone not feel shame or not feel guilt. We were helping people just identify how they were feeling, because you can't really get rid of emotions, right? But you can acknowledge them, and then you can have more power over them. And so we really worked on labeling emotions, and we worked on informal mindfulness to help people be in the moment. The cognitive reframing piece really leveraged some of the ideas related to self-compassion and reframing dysfunctional thoughts about the self. And ultimately, among at least some participants, I would say we were working to reframe dysfunctional core beliefs about the self. People said some very powerful things during this piece of the intervention. And during the cognitive reframing piece, everyone did have a log in their binder with compassionate self-reappraisals or self-statements that they came up with over the 5 sessions that we then used in the text component. And then the self-care goal setting at the beginning of the intervention, everyone came up with a self-care goal that we refined iteratively to make sure they were attainable. And we identified barriers throughout. So for the text component, starting in week 1 of the one-on-one portion, everyone got weekly texts asking about their medication adherence and asking about their substance use. And this went on through the duration of the entire intervention, including the 2 months after the 5 sessions. Notably, individuals in this open pilot proof of concept study mostly had Obama phones at the time, or little government phones that were Nokia phones, those little brick phones. This was in San Francisco maybe 3-4 years ago. So, and about half of our sample was marginally housed. So we had gotten feedback that if you have that little phone out and a message comes up, you can actually read. Anyone could read what's on it. Like, what drugs did you use today is probably not the best message to be posted there, right? So we leveraged Karen Ingersoll's question, how are the skies today? Which is a coded question for substance use. Rainy means you had alcohol, or how are the skies this week? Snowy meant crack or cocaine. We added hail for methamphetamine or any kind of amphetamines, cloudy for smoking, etc. In addition, during the 5 sessions, the 5-week period, everyone got 2 text messages a day. One asking, how are you feeling right now? And there were response options, including other, angry, anxious, content, and they were to write back. And then they got a second message, how are you feeling about yourself? Again, response options with an other, and people were to write back. In that last session, the 5th session of the one-on-one interventions, everyone had a list that they had compiled, which is an example on the right here of compassionate self-statements that they had written over the course of the intervention. Things like, I like myself, I'm more than just a junkie, I deserve to take all of my medications. And then everyone had a binder, and in the last session, one of the worksheets was the worksheet on the right, which is compassionate self-statements. So they chose, of the response options for how do you feel about yourself, which of the compassionate self-statements would be most helpful when they're feeling each of these feelings or self-related emotions. And then for 8 weeks after the 5th session, they were asked every day, as they had been before, how you're feeling right now and how are you feeling about yourself. And in response to that 2nd session, they got their statement back, sent back to them in a text. So, how are you feeling? I'm feeling anxious. How are you feeling about yourself? I'm feeling ashamed. You're more than just a junkie. You deserve to take your medication. And that's what I chose, and that's what I wrote. And then we asked them how useful was this? And the useful question was designed also just to confirm that they read the reappraisal. So really quickly, this was an open pilot proof of concept study. It only involved 10 individuals, and we recruited in 2 different locations, an LGBT HIV community health center, similar to Fenway, but much smaller, and a public hospital in their substance use and HIV treatment clinics in San Francisco General. The individuals who were in this proof of concept study were middle-aged, but they ranged from 28 to 60. They were fairly diverse, lower education, about 50% identified as homosexual, 50% reported ever being homeless. And you can see everyone reported more than one substance use, and these were meeting criteria for substance use disorders. So this was a highly active group in terms of their substance use. So in terms of the feasibility and acceptability, my question was really, would this patient population do this, right? Would they engage? And 8 out of the 10 participants attended all the 5 sessions. And we saw a 77% response rate to the individual texts, which I was impressed by, and 70% response during the follow-up period. And in terms of acceptability, when we asked them, how likely are you to recommend this to a friend on a 0 to 10 scale, 10 being definitely, our mean was 9.3, and our interquartile range was 10 to 10. So this group really liked this intervention. Similarly, when asked, would you recommend it to a friend who uses substances, the response was very similar, mean 9.7, and interquartile range 10 to 10. We did see some improvement in adherence. I don't think our data was long, we had a long enough duration to see meaningful improvement in engagement in care or appointment attendance. And I don't have that here, but I'm happy to share that data with anyone who's interested. The exit interviews were where I thought the information was most useful. One person said, I was taught to talk to myself like a best friend, makes me feel real positive. I'm actually inspired. It's a feeling of accomplishment, of being worthy, the opposite of not wanting and not being able to complete things. Another participant said, I like the fact that the study gives me ownership of what I want to create, my own positive, rather than somebody telling me, well, try this, because sometimes we have our own internal dialogue and we can talk ourselves out of situations. So I want to circle back to that case example that I mentioned before, that 26-year-old Hispanic gay identified man diagnosed with HIV recently or in the past few years. He actually went through the ACEs intervention, and he was really motivated. Again, at the beginning, he really described a lot of distress around his identity and his substance use and his some of his behaviors. And he really had a lot of trouble with self-compassion, as did multiple participants. At first, they thought it was weak, and they didn't get it, and they were there was even some anger, I would say, involved at the idea that this might be helpful. But by the 3rd session, this young man, as well as some of the other participants I'm thinking of, reported finding self-compassion to be very helpful, actually, and started using it in his daily life, he reported. By the end of the intervention, this individual reported reductions in his meth and alcohol use. He did not stop using either, but he did report in reductions, and he did report improvements in his medication adherence. So he started taking his medications more regularly. Again, we didn't see a change in appointment attendance, but we didn't have that long of a duration. And I think an important component is that he also reported that he felt more deserving of his partner's support. And that was something that was painful for him, and he had expressed tearfully in the past. And he really did feel that he deserved it, and he thought that that was linked to his reduction in substance use. So that's him. So he also, among several of the other participants, really did lead me to think about the importance of better understanding how specific intersecting stigmatized identities affect HIV self-care. So not just HIV and being a person living with substance use disorders, but also being a gay, bisexual, or other MSM. You know, this particular individual described a relationship with like the party and play scene that was different than some of the relationships to substance use that some of the other maybe heterosexual participants described. So one of my identified next steps out of this open pilot was to better understand how specific stigmatized identities affect engagement in HIV self-care. My other take-homes were, I needed to more rigorously assess the relationship between self-conscious emotion and engagement in HIV self-care, as well as whether avoidance mediates the relationship between self-conscious emotion and internalized stigma and engagement in self-care, to better refine the intervention to target the mechanisms of action. So I want to switch gears and tell you a little bit about what I'm doing now. My primary appointment is at Mass General, but I do most of my work, most of my research at the Fenway Institute. One of the studies I have underway now is the INSIGHT study. And And it's focused on better understanding how 3 specific stigmatized identities impact HIV-related self-care. So this study focuses on people living with HIV with problematic substance use who identify as gay, bisexual, or other men who have sex with men. And the goal here is really to look to see if these internalized stigmas may coalesce into an intersecting stigma factor, if you will, that maybe then does lead to lower levels of engagement in self-care. So we're testing that in 2 different ways. One is through qualitative interviews. I had originally proposed 30, but we ended up doing 33, and those are complete, and we're working on analyzing them now. And those involved individuals living with HIV, problematic substance use, and who identified as gay, bisexual, or other MSM. These 33 men also reported suboptimal engagement in care. So these are all guys who had trouble in some capacity with their HIV self-care behaviors. Concurrently, we're collecting self-report data, looking to collect from 207 men. We have 172 to date. And that is a self-report portion, involving men living with HIV, substance use, who identify as gay, bisexual, or other MSM. They do not need to be poorly engaged or suboptimally engaged in care, as we're looking for a distribution. We're looking to see what factors contribute. So if you know of anyone, send them our way. There are flyers on the table out there. Okay, and then I also have an Early Career Development Award from NIDA, looking to better understand and address internalized stigma and shame as a barrier to engagement in HIV self-care among men who have sex with men with substance use disorders. And this has 3 aims. I'm just going to touch on them briefly. One is to better measure self-conscious emotion using 3 sources of information. I briefly mentioned that Jessica Tracy and her group over at University of British Columbia have looked at behavioral and nonverbal measurements of self-conscious emotion. We're actually using those as well as a Penny Baker's linguistic inquiry word count, which is essentially a narrative coding structure. We developed a dictionary for shame and self-conscious emotions. And we're using those to better measure, and I'll tell you a little bit more about that in a moment. I'm also working on refining the ACEs intervention here in Boston. So we are doing qualitative interviews now with guys who would meet criteria, asking for feedback on those refined materials. And then we are planning to start a randomized control trial pilot to test feasibility and acceptability among 60 guys, 30 assigned to the intervention group. So really briefly, what I'm doing with the multiple measurements of self-conscious emotion involves interviews that Judy Moskowitz, who's actually at the Osher Center at Northwestern, collected when she was in California, which is how I know her. So she did 2 studies involving people recently diagnosed with HIV, and one is a cohort study and one is a intervention. So we use baseline data from both. She happened to ask people to describe their HIV diagnosis narrative or story. She videotaped it as well as transcribed the narrative and asked about emotion at that time. So we have self-report, we have a narrative that can be coded using the narrative coding structure, and we have the videos that can be coded for the nonverbal behavioral measurements. So this is underway now, again, to look at whether, if we measure self-conscious emotion in maybe the most accurate way we can, looking at these 3 sources of information, does that predict engagement in HIV self-care? And if so, does avoidance, which she also measured, mediate that relationship? And if so, we will target that pathway a little bit more explicitly than we already do. The refinement of the intervention has involved multiple pieces, including the insight study, which I mentioned, the results from that, which we've started to look at, the aim 1, which I just told you about, this measurement piece, and then the qualitative feedback, which we're actually asking guys feedback on the worksheets and the binder materials and the text platform and that kind of thing. So that's underway now. And then finally, this will kind of culminate in the randomized control trial pilot, which will involve 60 people, 30 in the intervention arm and 30 in a control arm. And the goal there will be to assess feasibility and acceptability. And we will do an exploratory intent to treat analysis on self-care, HIV-related self-care outcomes. So all that is really to inform future directions, hopefully. So I'm hoping to pursue a fully powered randomized controlled trial to assess efficacy ultimately. And then I would love to improve measurement of stigma-related emotions in order to better understand and address related barriers to self-care and substance use, and ultimately better understand and address stigma and shame as barriers to self-care among people living with substance use disorders, as well as people living with other stigmatized identities. And, I think it is worth saying that multi-level interventions are definitely needed to really address this problem of stigma as a barrier to self-care. And I think ultimately that does need to include not only individual level interventions, but provider level and structural level interventions to address these issues. And of course, efforts are needed to reduce stigma and discrimination among people with stigmatized identities in general. So we should work on that too. And with that, I want to thank everyone for having me, and all the people that have helped, and I would welcome any questions.
Are you going to use nonverbal cues as an assessment of an improvement in your therapy?
Yeah, so that is a tricky question. I would like to, if we find that they're useful. We are in the process of evaluating them now, and frankly, I'm not sold, but we're working on it. So if we do find that they are a more accurate measure of self-conscious emotion, yes, that's the goal, to include them in something like the MADRS or a clinical assessment of depression, where there might be a question at the beginning, how despondent does this interviewee look, right? Like, are they tearful? Are they hunched over? That kind of thing. That's how I would like to see it measured if we do find that it is associated in a clinically meaningful way with the other measurements of negative self-conscious emotion.
Hi, thank you for this. This is a wonderful talk. I'm kind of curious what you came across when you were doing the self-compassion pieces, because you're intervening on the individual level, but I know with partners and families, the internalized stigma often comes from people very close to our patients.
Yes.
So I'm kind of curious how your participants interacted with their family members or their partners, if they expressed that they were working on self-compassion, how that worked out for them. But
yeah, sure. So I can definitely share some anecdotes of that small sample. We did see one individual actually reached out to his mom. He was street homeless and addicted to heroin, actually. And during the 5 weeks, he reached out to his mom and got in contact with her. So who knows if that's generalizable in any way, but that did happen. Several individuals reported feeling more able to talk to their partners throughout the intervention. I agree with you. I think that there are multiple factors that are contributing to that internalized stigma. And I also think that it's imperative to kind of bolster oneself up enough to be able to kind of be in the world and have that kind of self-compassion. I do think it can be empowering, and it can help shift the dynamic. That is not to say that it's on the individual who's being stigmatized to take that on, but I do think it can enable coming from a more empowered place that can help people get what they need a little bit more. And we definitely saw that. The longevity of those effects over time, if they go back into the community or the relationships, are unknown. And that is exactly why I say we really do need multi-level interventions, I think, to have a long-term effect. However, I do think equipping the individual can be very meaningful.
Great talk, thank you. I'm really intrigued by your description of the resistance people felt to engaging in self-compassion in the beginning. And I've gotten some of that too. And I'm curious sort of what strategies you use to sort of help overcome that resistance.
Sure, yeah. So, I tend to use humor a lot in clinical contexts. So, I went with that. The manual itself, while I did write a full manual that's sort of a narrative, it's designed to be very flexible. And that was part of the reason, because we anticipated and we got resistance, right? So what we would do is we would introduce a concept like self-compassion. There was a glossary, so we went over the definitions. I would ask them to kind of bear with me through the worksheet itself, like the glossary or the definitions, the emotion glossary, and then say, okay, that's fine. We'll move on to the next exercise. And there were some like options, so people felt like there was a choice. And then we would circle back, like either at the end of the session or the subsequent week. And that seemed to work okay. And I didn't push it, while I didn't mention motivational interviewing is definitely infused throughout this work. I think, just working with people who use substances, that's sort of, what one does. It's like you roll with resistance. Like, okay, that's fine, So those are some of what worked for me. Mm-hmm.
Describing the ACEs study, you mentioned that you touched on some core beliefs that some of these people had about who they were.
Yeah.
Was that specific to these internalized stigmas, or were those broader things that were maybe applicable to a bigger population?
Sure. So I think they were, I would say both. So they were related to the internalized stigmas by and large. So things like I'm not worthy or I'm just a junkie, that came up actually more than once, those kinds of things. And I think those are applicable. As a clinical psychologist, I think those are applicable, not necessarily I'm, X, like a label that's associated with a particular stigmatized identity, but being unworthy or undeserving or less than. I find those to be very, very common across humans. So I do think it's generalizable, and I think they were related often to stigmatized identities. Mm-hmm.
Other questions?
Okay.
Thank you very much for that presentation.
My pleasure.